all these wonderful series of workshops. We have started this workshop on Monday, 7th, the first course of BLS, then on 14th Monday, the second course of BLS, third one on 21st of April, last Monday, and that is the final course lecture for this series. And for that, we are grateful and thankful all the organizing team, as well as I welcome Professor Dr. Mariam Morton. No, now everybody knows her very well, and she really needs no word for the introduction. Our panelists here are the two who are even at the stage of their internal medicine fellowship. Both of them are doing very well. They are looking after all the question answers and trying to satisfy all the participants. So welcome Dr. Sahar and Dr. Nasmi. Regarding the panelists, we have Dr. Sadia Ashraf with us, and definitely she's looking after ChestCon and very busy in doing a series of workshops. And the upcoming ChestCon is on 2nd, 3rd, and 4th of May in Peshawar, Serena. And Sadia is coordinating as a president of Pakistan Chess Society, KP chapter, as organizer. Please, anyone who is interested for other workshops, they'll come and join that. I took an opportunity to share this information. And thank you, Dr. Walid and the rest of the people who are looking after. Now, I request Dr. Mariam to please continue with her wonderful lecture. Hand it over to Professor Dr. Mariam.
Thank you so much, and Assalamu alaikum to everybody for coming. I really appreciate everybody's interest. And as you know, I'm a graduate of Dow Medical College, and I'm now in USA as a professor of medicine at UNLV. Today's topic is ACLS Overview Simplified, and we'll be doing part 2 today. So as you all know, the ACLS requirements are pretty basic. They want to make sure that you know the basic life support code. There are no exceptions for it. So you should practice and remember what BLS stands for before you go into advanced cardiac life support. Principles of early defibrillation are equally important, and you need to know about it. Systems of care have been discussed briefly in the past seminar, and we will try and emphasize on it a little bit more today. We will definitely talk about the ACLS cases. We have done stroke already, and we will be dealing with the cardiac ones today. We will also discuss some of the multiple choice questions that have been given out to you for you to solve, and will help you also with your Viva. Of course, there will be some discussion about the mega code and how it goes and it processes through in different workshops. Remember, these lectures are there to help you overcome your fears about ACLS. ACLS is important, and you need to know it, and you need to do well in your ACLS competency testing at your own institution. So if you listen to the lectures and you go for your ACLS competency, I'm sure most of you will do well. As far as conflict of interest is concerned, we have no conflict of interest. These are there for all of us. That includes Dr. Amber Ashraf, Dr. Sadia Ashraf, Dr. Seher Mahani, Dr. Nazanin Hoshman, APCNA, Apna, and the hospitals in Pakistan. We all gotten together to make sure that we increase bystander CPR response rate in Pakistan. We want to improve the CPR performance in general, and we want to increase public awareness, as well as improve the public and medical professional education and training as time goes along. As you all know, ACLS requires you to feel for your own safety. Safety comes first, and then you look at the person that you're trying to help, make sure that they're conscious or unconscious. Based on that, you decide if you're going to start the chain of survival. If the person is unconscious, the chain of survival starts right away. And you need to consider looking into if you need to deliver high-quality chest compression, and if the person is adult, child, or an infant. Important to know where to locate and understand how to use an AED. We have discussed that in the previous sessions. And also you need to know how to provide rescue breathing when appropriate, and we have discussed and shown you the pictures of that. You also need to know how to treat choking. These are part of the requirement for the ACLS. And finally, you need to understand how to perform as a team. Sometimes we tend to forget the team in the end because we too busy doing other works. But it's important to debrief and understand how we should be performing as a team and what is it that we can do to make ourselves better. There's some key algorithm for ACLS that you need to know. These are structured protocols that are used in an emergency to manage 4 cardiac and 1 suspected stroke. We have talked about the stroke in the last session. We'll be talking today about the cardiac arrest algorithm, which guides you through the management in cardiac arrest. We'll talk about the bradycardia algorithm. It provides the steps for slow heart rates. We'll talk about the tachycardia algorithm and how to approach a patient with fast heart rates. We'll be also discussing acute coronary syndrome and its algorithm with focus on management of patient with chest pain or suspected heart attack. And of course, as I mentioned, we have already discussed the stroke algorithm in which there is rapid assessment and treatment for stroke. These are standardized approaches for diagnosis and treatment, mainly meant to improve the efficiency and care of the patient. So everybody has the same kind of protocol to follow, so you know what step to follow and where to go from. The 5 activities for ACLS workstation and mega code that you need to know, those of you who are taking the mega code today will find it useful. One is to know about the early management of respiratory arrest, recognition and management of acute MI, talking about the cardiac arrest, usually which is treated as mega code at most places, and they will go and take you through multiple algorithms in different hospitals, wherever you're doing your ACLS training. Bradycardia diagnosis and management steps are also discussed in a lot of workstation, as well as tachycardia diagnosis and management steps. Remember, your instructor may change the screen on you a couple of times, so you need to be careful. Look at the screen, find if the person is tachycardic, if the guy is bradycardic, and then make sure you look at the patient too and know what is going on with the patient. Is the patient alive? Is the patient talking? Is the patient conscious? Does he have a pulse? Yes or no? And go accordingly. So the first case that I'll discuss is about the respiration. A person that comes to you who is not responsive, has a pulse, and is not breathing. Think about a person that comes to the emergency room with shortness of breath, and he loses consciousness in front of you in the emergency room. And you check him, he's got a strong pulse, but he's not breathing. And as part of the protocol, you're supposed to ask for help. Once you push the help button, if you call for a rapid or if you call the EMS, whatever is your hospital protocol is what you need to do. Then after that, you just have to look at the initial actions that you need to do. Number 1, you must make sure that the airway is open. Either you can do a head tilt chin lift, as shown over here, or you do a jaw thrust. In a person that may have cervical injury, you're really not going to do a head tilt and chin lift, but you will do a jaw thrust. So it all depends on what circumstances you're dealing with. And then you have to initiate ventilation with a bag mask valve device. It is required in US to know how to use the bag mask valve. Recommended rate for adult for rescue breath is 1 breath every 5 seconds, and you must see the chest rise with every breath. If too much air is given to the person, it will cause gurgling or air in the stomach, and then your compressions are not going to be adequate if you need to do CPR, or if the person has a lot of air in the stomach, then suctioning will be required, and that will delay giving the next breath, and that may not be the right thing to do. In the airway management, as I mentioned, you need to learn how to use the bag mask valve. It's not difficult. At first, you may find it a little cumbersome, but after using it a couple of times, you'll find it easy, and it helps you a lot in giving the ventilation to the person. You need to know about your basic airway adjunct, which is the oropharyngeal airway, and you use it only in a person that's unresponsive with no cough or gag reflex. And this is how they look like on the right side. The nasopharyngeal airway is the one that can be used in a conscious person with intact cough and gag reflex. And these are the green tubes as shown over here. And you can pass it through one of the nostrils. And they are useful when you have to do suction. Whenever you want to suction a patient, make sure you don't do suction for more than 10 seconds. You put the catheter in, put your finger in, and pull it out right away. Don't take more than 10 seconds. If you exceed 10 seconds, then you may not be able to give them the breath that are required. Adjunct airways, advanced ones are important, especially people that are anesthesia resident. And I understand we do have a few anesthesia resident here. They need to know about the endotracheal tube, the laryngeal mask airway, laryngeal tube, esophageal tracheal tube. And these will be shown to you at your station when you go to the respiratory station. And it all depends on what is available in your hospital, and that's what they will be showing it to you. So in early management of respiratory arrest, you need to know either you need to do bag mask ventilation, or if the person has an advanced airway, how to handle it. Pre-hospital or in-hospital intubation, those that are in anesthesia, you need to know there has to be an ongoing quality improvement program if you're dealing with an intubated patient, mainly to minimize complication and to track the overall success rate. The next case is, as you all know, we all talk about chest pain patient. Think about a person who is middle-aged who comes to the hospital and he complains of lightheadedness and chest pain. Generally, most people that come in with chest pain, they are not feeling well, they're sweaty, they're uncomfortable, and the vital signs may be different. They're generally tachycardic or they may be hypertensive. And in this particular case, you find his pulse rate is good, 88, but his BP is elevated and his respiratory rate is elevated, but his pulse ox is good. So the question may come up to you and you may be asked, what is your initial step in this patient's management? Do you want to activate the cath lab and the STEMI protocol because this guy came in with chest pain? Or do you want to initiate compression because he's looking sweaty and uncomfortable? Or do you want to place this patient on a monitor, establish IV access, gather history and physical examination, provide some supplemental oxygen and get an ECG, or give them a beta blocker? And as most of you are answering, yes. If a person comes with chest pain and is uncomfortable, ECG is done as soon as possible. Within minutes of his arrival, STEMI is very high in the differential. But remember, every chest pain is not always an ACS, and therefore you need to get some history and examine the patient to find out what is going on with the patient. So if this patient has come up to you and now you notice that his heart rate has gone up, his 110, blood pressure has kind of normalized, 130/80, respiratory rate has normalized, but his pulse ox is falling on you, temperature is normal, below normal. So the question comes, what is your next course of action for his oxygenation? Do you need to worry about oxygenation, yes or no? And how do you want to deal with it? Do you want to give him a nebulizer treatment? Do you want to start him on oxygen, like 2 to 4 liters per minute per nasal cannula? Do you want to intubate this guy because it was 93 and now he's 85 and you're worried that he may get worse? Or you can just watch him and do not start oxygen. And as some of you are answering, yes, you have to start the person on oxygen 2 to 4 liters per minute per nasal cannula because he's not ready for intubation. Yes, you just have to give him oxygen to bring up the pulse ox. So this patient, now that comes, you're getting a little bit more history on him. It's chest pain. He's telling you that it started about an hour ago. And since then he has been sweaty and having a nauseated feeling. And it got better, but it recurred within a few minutes. That's the typical, patient that comes to you, chest pain getting better, waxing and waning. And he states that he's become intense a few minutes ago while he was walking towards the check-in desk. So when the person complains about chest pain getting worse, within the first 10 minutes on the basis of patient's current symptoms, more often than not, we have to do a lot of things. What would you do? Do you want to assess his airway, breathing, and circulation? Do you think he needs an epinephrine? Do you think you need to consider nitroglycerin, morphine, and clopidogrel because you're thinking about angina and unstable person? Do you want to give him oxygen if the O2 sat is less than 90 per nasal cannula? Do you want to activate the STEMI protocol, or do you want to get a 12-lead ECG or give aspirin and establish an IV access? And some of you, as you are answering, you will do everything except not worry about giving epinephrine. He's already tachycardic. You don't want to make him tachycardic. He has a pulse. You don't have to give him epi. So once the IV is started, oxygen is given and monitor is applied. The patient's vital signs remain unchanged. And the person that does the EKG brings over the EKG to you. And you're expected to know how to recognize the changes in the EKG and what does the EKG shows. So this guy has chest pain and the EKG is brought to you and it's shown below as I just showed it to you. Now you need to know how you would read this ECG. Do you want to call it as a normal sinus rhythm with PVC? Do you want to call it as a posterior MI? would you like to call it as ventricular tachycardia, or call angiostemy? And as some of you are answering, it is an angiostemy because you're seeing ST elevation as shown in the example on the side. And therefore, you need to worry about this patient a little bit more than when he came in earlier. So when the person comes with a diagnosis of STEMI, your treatment strategy escalates and you need to decide what to do next with the patient. Do you need to admit this guy for PCI or fibrinolysis? Do you want to release this patient to home so he can relax at home? Or do you want to put him under observation? Or do you want to admit him to an ICU? And most of you, like you were saying, yes, you want to treat him with thrombolytics or give him a PCI if you can have that at your institution. So the admission for PCI and fibrinolysis, as most of you are getting it, is the right answer. So in acute MI, if the person is still complaining of chest pain, you can give him some medication, but the question comes, what kind of medications are you giving to the person when it comes with an acute MI? What is the most important one? Do you give him the nitroglycerin? Do you give him the metoprolol? Or do you give him the aspirin? Or give him the atropine? And as some of you are answering, yes, the answer is aspirin. It has been proven to improve morbidity and mortality in STEMI patient and is given as soon as possible. Early intervention with cardiac cath is imperative in this individual. If emergent cath is not available, it may be not in a lot of institutions in Pakistan, thrombolytic therapy then is provided to the patient. Of course, now if the patient is still complaining of chest pain, then you need to give him additional medication. And a lot of people go with different kind of strategies as what medication should be given next. But generally, there are protocols that are written, what you should be giving to the patient next. Would you like to give morphine sublingual 1 to 3 minutes? Do you want to give him morphine IV 1 to 3 minutes? Do you want to give him nitroglycerin IV 1 to 3 minutes? Or do you want to just give him sublingual nitroglycerin once every 3 to 5 minutes? The protocol says sublingual nitroglycerin is the one that you need to give to the patient first because it's the fastest acting one. And for that, you don't have to worry about the IV access if the veins are appropriate, yes or no. So summarize in this particular patient, the ECG is showing an angiostemy with the ST elevation, as you can see in the anterior leads over here. Aspirin is given as soon as possible, and you have to give them 324 milligram of aspirin, which is chewable or fast-acting, not the enteric-coated one, because enteric-coated will take a while to be absorbed. You use the plain aspirin, non-coated one. And it is given to improve morbidity and mortality in a patient with STEMI. Early intervention, either with cardiac cath or with thrombolytic, is important. In US, we try to push them all to early intervention via cardiac cath. If emergent cath is not available, then you can think about thrombolytic therapy. So as most of you know, thrombolytic therapy is second line in US, not PCI is the first line. So for acute MI protocol, when a person comes to you, you need to remember to connect them to cardiac monitor or activate the EMS system, depending where you're located. You need to look at the patient's oxygenation, give him the aspirin, give him the nitroglycerin. You can add on to morphine later on, but generally you try to get the consent about the patient about the PCI first before you start giving them more morphine. 12-lead ECG is equally important. That's the important thing that has to be done within 10 minutes, and getting an IV access and notifying the cath lab so that the patient can go to the cath lab if you're seeing somebody with a STEMI. So the question that is very important that comes in a lot of US ACLS classes, what is the goal of PCI when treating this patient? Is door to needle time of 20 minutes? Is his first medical contact to cath lab time of 30 minutes? First medical contact to balloon inflation time of 90 minutes? Or door to balloon inflation time of 120 minutes? And I know most of you do know the answer, but international guidelines are the ones that you need to follow for yourself in Pakistan. First medical contact balloon to inflation time of 90 minutes is extremely important. International guidelines stipulates a first medical contact to balloon time, which they call is FMCBT, of less than 90 minutes per person with a STEMI. So that's very important for you to remember. You made the first contact with the patient and the patient comes to the ER to the balloon time. It has to be less than 90 minutes. Of course, this patient can get better, chest pain get better, but more often than not, this patient, if you don't intervene right away, they can code. So after aspirin therapy in this particular patient, as an example, he's still complaining of chest pain and suddenly becomes unresponsive. And that's when the mega code for your ACLS class starts. And they will show you your instructor will show you the cardiac monitor with this kind of rhythm, where you really can't define a QRS complex. And it's a wavy kind of a complex, and the rate is very fast, and you don't know what's happening. So this is a rhythm that you need to worry about. So the question comes up, what is the next step in its management? Do you want to give a memudrone? Do you want to cardiovert the person as soon as possible, defibrillate as soon as possible, or give him epinephrine? So the answer is VFib is a non-perfusing, life-threatening rhythm. Anyone that has a non-perfusing, life-threatening rhythm must get early defibrillation. Just because you cannot define a QRS complex, which are good, putting in a synchronized button is not going to help you with this patient. Not at all. And you should make sure that the synchronized button is off when you're trying to defibrillate this person. You start CPR and manual bagging for circulation and breathing while the defibrillator is charging. As soon as the defibrillator is ready, you have to defibrillate the patient. And this is well written in the AHA guidelines, and you need to carry this in your pocket so you know how to deal with a person that is a VF, a pulseless ventricular tachycardia, asystole, or pulseless electrical activity. What do you do next for the patient? So to summarize what has been shown in that table, cardiac arrest pulseless patient this protocol is for patients that have ventricular fibrillation. They may have pulseless ventricular tachycardia. They may be asystolic or have pulseless electrical activity. First and foremost, you check for responsiveness and call for help. Activate your EMS response system and get an AED or defibrillator. In the hospital setting, you get a defibrillator. In the outside world, you may get an automated external defibrillator. Automated external defibrillator may not necessarily have a screen, and you wouldn't know what the rhythm is. You have got to start a high-quality CPR 30-2 ratio. You need to push hard. You need to have at least 2 inches depth in an adult, and you need to push fast, 100 to 120 times per minute. And then attach the defibrillator and assess the rhythm. If it's a shockable rhythm, you deliver the shock and resume CPR immediately for 2 minutes. If it's a non-shockable rhythm, asystole or PA, you need to continue CPR and give epinephrine every 3 to 5 minutes. Medications are given as needed. More often than not, you're giving epinephrine 1 milligram IV every 3 to 5 minutes. Somebody had put up this issue about the adrenaline. It was used in the past, but not used anymore in US or in Europe. And it has been off the American Heart Association ACLS protocol for well over a decade and a half. The second medication that we try to use in patients is imidrone in US, whereas in other countries, it may be lidocaine for persistent VF or VD. You need to continue a cycle of CPR and shock as applicable till you have return of spontaneous circulation, or you need to terminate the resuscitation effort. So you need to decide which way to go after a certain period of time. So adult cardiac arrest algorithm, you need to always remember to start CPR, give oxygen, attach the person to monitor and defibrillator, check the rhythm, and based on that, you decide if you need to shock the person or not. This is the other one that is there in the American Heart Association, published in 2020, and you can keep that protocol in your pocket when you're on the wards. For principles of early defibrillation, as we have discussed in the past, always remember oxygen is not flowing across the patient's chest when you're delivering a shock. And it's important not to stop chest compression for more than 10 seconds when assessing the rhythm. And remember to stay clear of the patient and shout out clear for everybody before you deliver the shock. And it's important to assess pulse after the first 2 minutes of CPR. We also tend to check the end-tidal CO2. And if it's less than 10 millimeters of mercury during CPR, then you need to consider adding a vasopressor and improve chest compression. However, after 20 minutes of CPR, if there's in a person that's intubated, you may consider stopping your resuscitation efforts. So 20 minutes of CPR is what is generally recommended in a person that's intubated and you've seen that person pass out in front of you. Then you may need to continue in a person that's not intubated a little longer, but generally 20 minutes for an intubated person is what the AHA recommends. While somebody is doing the compression and looking at the monitor and giving the IV drugs, the other team members need to continue identifying and treating, looking for reversible causes of cardiac arrest. There were first 5H and 5Ts, now there's 6H and 6Ts. They include hypovolemia, hypoxia, acidosis, hypo or hyperkalemia, hypoglycemia, and hypothermia. In the Ts, we include tension pneumothorax, tamponade toxin, thrombosis, whether coronary, pulmonary, and unrecognized trauma. Unrecognized trauma and hypoglycemia has been added on recently into your reversible causes of cardiac arrest. So to summarize adult cardiac arrest, when you go to the Omega code, remember your CPR quality is very important. You must have 30 to 2 compression to ventilation ratio. If you miss that, the chances are you may not pass your ACLS. It's the core part of your ACLS. Shock energy, depending on what kind of machine that you have, is it a biphasic or monophasic? In US, most of the defibrillators are biphasic, and some places they may be monophasic still. In biphasic, you use 120 to 200 joules of maximum, whereas in monophasic, the current is much higher, 360 joules. You look for return of spontaneous circulation. This is seen by a sudden sustained increase in bed CO2, typically greater than 40 millimeters of mercury. And you may look into advanced survey if the patient needs to be intubated and if you can give 10 breaths per minute once the person is intubated with continuous chest compression. Look for drug therapy. What have you given? There's somebody who is monitoring, writing down what drug has been given, and they need to notify you to make sure that epinephrine is given every 3 to 5 minutes. Amiodarone is given first dose 300 milligram and second dose is 150 milligram. Lidocaine first dose is 1 to 1.5 milligram per kg and second dose is 0.5 to 0.75 milligram per kg, or unless the QRS complex starts widening or the rhythm disappears. And of course, you need to look for the reversible causes, as like I mentioned, the H and the T's, which are now 6 and 6. Now, moving on to arrhythmias. In the arrhythmias, 2 things, bradycardia and tachycardia, are the 2 things that you watch out for. Symptomatic bradycardia is important. It could be a person having a sinus rhythm. It may be a novel within slow heart rate as shown on the top, or it may be associated with first AV block in the second screen when the PR interval is long and greater than 0.2 seconds. That's the first one. The second, type 2 second degree AV block is the second tracing on the side. There's a one that you are looking for in where the PR interval may be prolonged before random QRS is dropped. The third degree AV block is when the P wave and the QRS are not talking with each other and they're not coordinated with each other. Of course, you can have somebody with symptomatic bradycardia with slow AFib and atrial flutter, or the person may have junctional escape rhythm. So it all depends what the rhythm is. You have to tailor your treatment accordingly. But the important thing is to know if the person is symptomatic or not. Bradycardia by textbook is resting heart rate less than 60 beats per minute. For ACLS, we try to look at typically heart rate less than 50 if there is bradyarrhythmias, and you look for appropriateness for clinical condition. Sometimes we cause bradycardia in the patient by giving them beta blockers, giving them calcium channel blockers, something to help them then slow down the heart rate for one medical reason or the other. And those patients just need to be observed. They don't need any kind of special treatment. Of course, if the person is symptomatic, then you have to identify and treat the underlying cause. Important thing is make sure you have a patent airway, you assist breathing as necessary, and give oxygen if hypoxemic. A lot of patients are in US use CPAP, and if they get hypoxemic, they become bradycardic, and it's very important to know that. Cardiac monitor is used to identify the rhythm, and it's very important to monitor the blood pressure and oximetry. You need to get an IV access on them. because you never know when you may need to give them the medication, and get the 12-lead EKG as soon as is available, but don't delay treatment if it's necessary if the patient looks bradycardic to you. And it's important to consider possible hypoxic and toxicological causes. The causes that we always look out for: what are the problem with the patient, and what kind of symptom is it causing to the patient. So in the symptoms, you're looking for hypotension, you're looking for acutely altered mental status, looking for signs of shock, and see if the patient is ischemic or having chest discomfort or has gone into heart failure. So the basic causes of bradycardia are four. Number one, myocardial disease. Either the person has myocardial ischemia or is having an infarction, especially in fuel MI. You'll find patients pretty bradycardic. Drugs and toxicology, calcium channel blockers, beta blocker when they overdose, or digoxin, or if the patient may have used some kind of drugs on the street and they may have become bradycardic from there. Hypoxia, as I mentioned, is also cause of bradycardia, and you need to treat it. Electrolyte imbalance is equally important, especially if you come across a patient that has renal failure and you look out for hyperkalemia in those people. And more often than not, treating the underlying cause will help them bring up their heart rate. So if a person is symptomatic and the heart rate is less than 50, you need to help them out. First thing is to maintain an airway and give oxygen as needed and monitor the vital signs. You can give them the atropine, 1 milligram every 3 to 5 minutes with a maximum dose of 3 milligram. And if atropine fails, you can consider transcutaneous pacemaker, which is an external pacemaker, and it's pretty painful. So if you can sedate the patient a little bit, it will help. And give them the lowest possible dose that can cause their myocardium to contract. Dopamine is important. You can give them dopamine or you can give them the epinephrine drip. But important thing is don't forget to ask for help. In the mega code, you're allowed to ask for expert consultation. You say, okay, go ahead and get somebody to tell me what should I do next. That's not a problem. So the usual question that you may be asked is, a patient has symptomatic bradycardia with a heart rate of 32 per minute, and that's also included in your multiple choice question. Which of the following are acceptable therapeutic options? Is it something like atropine, epinephrine, dopamine, or all of the above? And as you're mentioning, as we have discussed, atropine is the initial treatment for symptomatic bradycardia. And if unresponsive, you can give them IV dopamine or epinephrine as the next step, and pacing may be effective if other measures fail to improve the rate. So the answer is these. You can use atropine, epinephrine, or dopamine, depending on what is needed. But first line is the atropine. You start with the atropine, then you decide if I need to give him dopamine or epinephrine. Tachycardia is the other rhythm that you need to deal with as part of your ACLS. And tachycardia, we call it when the heart rate is greater than 100. Patient may be symptomatic or may be asymptomatic. And for the ACLS, you're looking for a person that's symptomatic, not that is asymptomatic. You're looking for a problem that may have caused their heart rate to go up. If the patient is having a PQRST and the heart rate is looking good, and the patient is not that symptomatic, P and the QRS complex are talking to each other, you need to look for underlying causes. If the blood pressure is good, you find out if the guy is anemic, if he's having any other issues. However, SVT is a different breed. SVT is a faster rate where you won't really see a good identifiable P wave, and the rate will be much faster, as shown in the second ECG strip there. Or you may come across somebody who has SVT with aberration, and that's when we all run into trouble. We are not able to define if it's SVT with aberration or is it ventricular tachycardia. We're looking for P waves coming here and there and not talking to the QRS, or if we can define a retrograde P wave. And we go through a lot of differential. But, if the person is symptomatic, then the treatment is synchronized cardioversion. You don't really wait for finding out what the cause is. Of course, you can come across patients with atrial fibrillation or atrial flutter, as shown in the last strip at the bottom, lead number 2 at the bottom. The rate is fast, and the treatment will vary depending on how the person is doing. You may need to give them medication, or you need to give them a synchronized cardioversion. Anyone that has a good QRS complex and has a pulse, it's always a synchronized cardioversion. So in a person with tachycardia with a pulse, you look for signs and symptoms and look at the heart rate, try and identify and treat the underlying cause. You maintain their airway, assist them with breathing as necessary. If they're hypoxemic, you need to give them oxygen. You need to connect them to cardiac monitor to identify what the rhythm is. You need to check the blood pressure and pulse oximetry. Vital signs are extremely important. Without the vital signs, you really don't know how to proceed forward. You need to have an IV access in the patient and get a 12-lead ECG to help you out on the rhythm as to what kind of a rhythm it may be. So for tachycardia algorithm, as per the ACLS criteria, you need to find out if the person is symptomatic, fast heart rate that causes chest pain. If they have low blood pressure or shortness of breath, then it needs to be treated right away. The steps are, number one, you assess the patient. Is he stable? Then you need to go to medication. If he's unstable, then you need to do immediate synchronized cardioversion. By unstable, I mean if the patient has got low blood pressure, patient's having chest pain, or having an altered mental status. If they're stable, you need to identify type of tachycardia. A person that has a narrow QRS complex is likely to be an SVT. You can try vagal maneuver, but remember you need to feel the carotid pulse, and you need to listen to the carotid, make sure there's no audible bruit. Then you go ahead and do the carotid massage. You can have them bear down. And sometimes this may help in some individual. And those people that get proximal supraventricular tachycardia very often, we tell them, to these kinds of maneuver, bearing down, putting ice on their face, splashing cold water. And those kinds of vagal maneuvers do help break down their PSVT. The second thing is to give them medication. Usually we give them adenosine, 6 milligram IV push, then 12 milligram as needed. Of course, you go by 6, 12, 12. Some places will go 6, 6, 12, but generally it's 6, 12, 12 in US. To give 6 milligram of adenosine IV push, and then, followed by saline. It has to be a fast push and then the saline. And that will make some patients symptomatic. Why QRS complex? It more likely than not, it could be VT, especially in an older person. You need to think about it. Give them amiodarone, 150 milligram IV over 10 minutes and see if it helps slow down the heart rate. If a person has persistent tachyarrhythmia, then you need to decide if I can give him synchronized cardioversion or should you treat them with medication if they have a pulse. If the person's tachyarrhythmia causing them to have hypotension, they have altered mental status, they have some signs of shock, chest pain, or acute heart failure, you may not have much time. You need to consider synchronized cardioversion, and generally, if time permits, you give them some sedation. If there are no symptoms, then you can consider giving them adenosine only if they have a narrow QRS complex and the blood pressure is okay. You need to consider it only if it's regular and monomorphic. Otherwise, you need to consider intra-arrhythmic infusion, and it's important to look for expert consultation. They may help you out. The cardiologists are there. They will be able to help you guide through and give the medication. And if the person has any issues, they can help you out to overcome that. The question for SVT generally is asked is, you have just administered a drug for an individual with SVT. She's complaining of flushing and chest heaviness. Which drug is the most likely cause? Is it aspirin, adenosine, amiodarone, amitriptyline? Yes, I know aspirin can cause some of the side effects, but generally the answer is adenosine. Adenosine is the correct choice for SVT treatment, and it commonly results in reactions such as flushing, dyspnea, chest pressure, and lightheadedness. A number of patients will say that I feel like I almost passed out. I lost almost my consciousness. That's how bad a feeling can it be. And the blood pressure will drop down momentarily and then come back. And same thing about the heart rate. It will almost disappear. They'll almost have the ACs to leave for a few seconds. And then they will have the narrow, regular QRS complexes with the P wave before that. So a person with the cardioversion and meds, you just need to know the details for doses, how to do it. Synchronized cardioversion, narrow QRS complex, don't have to give them the full current. You can give them 50 to 100 joules, and usually we use it for the biphasic one. Narrow irregular biphasic, you need to use a higher current, 120 to 200 joules, whereas in monophasic, you need to give them a much higher dose, which is 200 joules. Monophasic means that the current is only coming from one side, not from both sides. wide regular complexes, you can start with 100 joules, but if it's irregular, then you don't have time for synchronization. Then you have to use a defibrillation dose. It's because it will have difficulty synchronizing if it's irregular. However, if the patient has a pulse and if it looks like an AFib, yes, you can synchronize and you can do it. Adenosine IV, initially, as I mentioned, 6 milligram rapid IV push, then you give a saline flush, followed with a second dose of 12 milligram if needed in order to break the SVT episode. And diarrhythmic infusion, as we have discussed last week, you can give them procainamide, and you can give it as an infusion till they are doing better. Usually it's given as 20 to 50 milligram per minute until arrhythmia is suppressed or hypotension or QRS increases by 50% from baseline, or maximum dose of 17 milligram per kg is given. Maintenance is 1 to 4 milligram per minute, and you need to avoid it if there's prolonged QT or congestive heart failure. Immunotherapy dose is 150 over 10 minutes and repeat as needed if VT occurs, and maintenance is 1 milligram per minute for the first 6 hours. IV sotalol 100 milligram is generally given over 5 minutes. It's usually in the dose of 1.5 milligram per kg, but you need to avoid it if there is prolonged QT. Torsade is other thing that comes up in the exam, and you may come across a patient who is an alcoholic, and what we find is a person is in torsade. The torsade is a rhythm, which is QRS complex that is twisting around a point. That means they're getting bigger and they're getting smaller and they're getting bigger again. So the usual question that comes out in those people is what intervention is most likely to correct the underlying problem? Is it rewarming the individual to correct the hypothermia because alcoholics tend to be hypothermic? Or do you need to give them magnesium sulfate? Or do you need to give them glucose to correct hypoglycemia? Or do you need to give them naloxone to correct a narcotic overdose? Generally, when you see a torsade in an alcoholic, the answer, like most of you are mentioning, hypomagnesemia or low magnesium is commonly caused by alcoholism, and you need to give them that magnesium first. Administration of IV magnesium may prevent or terminate the torsade point. These are some of the top rhythms that are put in together by one of the nurse, and these are the rhythm that you need to know for your exam. Normal sinus rhythm, you have a P wave and a QRS complex, followed by a T wave with a repolarization, and then you have PQRST, and all of them are regular, and they are all looking alike. Sinus tachycardia is when the heart rate is greater than 100, means the heart is pumping too fast, but it's regular, and it looks just like the normal sinus rhythm, but the rate is much faster, greater than 100. Sinus bradycardia is when the heart is pumping too slow, but it's regular and looks similar to normal sinus rhythm, but it may not be enough to sustain a patient's, may cause the patient to be symptomatic and may not give them enough perfusion that would help them stay awake. Atrial fibrillation is when the atria are cooling, that means you will not see a good P wave at all. You will see wavy baseline, and the QRS complexes will vary in frequency. That means that the EKG will appear to be irregularly irregular. The QRS complexes will be irregularly irregular. Atrial flutter is when you have a sawtooth appearance, means there's some activity of the atria and it's kind of organized, and the QRS complexes are coming in. They may come in a regular fashion or they may come in an irregular fashion, depending on how the block is. Is it a 2-to-1, 3-to-1, or is a variable AV block? Ventricular fibrillation is the most dangerous one. Ventricles are curing, that means there is no contraction of the ventricle. And that's when the heart needs the most help, and you need to shock those patients, defibrillate the patient. Ventricular tachycardia is when the ventricles are pumping too fast. And torsade point is what, as I mentioned, is twisting appearance that you will come across. The other rhythm that are generally shown in the ACLS are first AV block when the PR interval is prolonged, and then suddenly the instructor may change it to second degree type 1, or they may change it to second degree type 2. So you need to be able to recognize those rhythms, and sometimes they may go into third AV block. Asystole is when there is no atrial activity that you can see on the surface, and those are the patients that you need to start the CPR right away. Pulseless electrical activities, as I mentioned in my last talk, when the person does not have a pulse, is unresponsive, and is not breathing. When that happens, doesn't matter what the underlying rhythm is, yet the underlying rhythm is completely sinus, looking like a normal rhythm. But if you don't see it, you have got to start the CPR right away. In systems of care, the important thing to know is about the unstable patient. Depending on the institution where you are, if the patient looks unstable to you, generally most places will call a rapid response team, which comes within a few minutes. But if the patient is going blue on you, doesn't have a pulse, you need to call the code team. Rapid response team will may escalate it to a code team depending on how they see it. But if you see it first, you are expected to call the code team. And then the code team may pass it out to the critical care team once the patient is started getting a little bit stabilized, or the critical care team is able to get organized and come and help you out. So the key component for ACLS are return of spontaneous circulation. When there's return of spontaneous circulation, there's oxygenation and ventilation, but you need to provide blood pressure support, and you may need to consider targeted temperature management and do a neurological assessment. By that, I mean, first, optimizing oxygen and blood pressure, maintain oxygen saturation greater than 94. Some books will say 93. Give blood pressure systolic greater than 90 millimeters of mercury. You may need to give the person IV fluids. You need to give them epinephrine, or you need to give them dopamine, anything to keep the blood pressure up. 12-lead ECG is important. As soon as you get the ROSC, you need to check for STEMI. STEMI is very important, and sometimes, patients may come with full arrest, and once you bring the ROSC, that's when you do the EKG and send them to the cath lab. Targeted temperature management requires the patient to be cooled down at 32 to 36 degrees for minimum of 24 hours if they continue to remain unresponsive. And neurological monitoring is important. You need to make sure the brain function is checked and make sure that seizures are being prevented. Post-cardiac arrest, airway management in general, you need to give the pulse ox in a place where it's safe. 92 to 98% is the usual goal. And you titrate the PaCO2 to 35 to 45 millimeters of mercury. And in US, we use waveform capnography. It tells us how the patient is ventilating. For blood pressure support and vasopressor, you need to make sure you have an ECG, you support the blood pressure to 90 millimeters of mercury, and if you have an art line, mean arterial pressure should be greater than 65. That's important. Unless contraindicated, first line of therapy in a person with low blood pressure is giving them fluids. IV saline or lactate adringer. Some people say, my patient's got a heart failure, his EF is 10%, I won't give him fluid. No, you can give him the fluid and get rid of the fluid by giving them diuretics later on. Then vasopressor and inotropes are important. Pressor of choice is epinephrine for those that are not in cardiac arrest. Dopamine and phenylephrine are the alternatives to epinephrine. Norepinephrine is generally reserved for severe hypertension or is a last-line agent. Hypothermia is important, and it's important that you induce hypothermia for at least 24 hours because the recovery may happen in some individuals. As I mentioned, therapeutic hypothermia is important. Optimization of hemodynamics and ventilation is important. Give them the fluids and vasoactive medications as necessary. Send patients for thrombolytics or PCI, depending on the institution, if they have a STEMI. And neurological care is important, especially when you're withdrawing care. You do not know if the patient is brain dead or not. And it's important to look for specialty consultation, mainly to monitor neurological signs and symptoms in post-resuscitation period. Most of these patients are sent to the ICU in US, and that's where they are monitored. In pregnant women, it's a little different. Post-arrest step generally focuses on maternal resuscitation, and therefore there has to be preparation for early perimortem C-section delivery if necessary. You can save the infant and also improve the chances of successful resuscitation of the mother. ACLS termination of resuscitation, you can do it when the arrest was not witnessed. There was no bystander CPR. There's no return of spontaneous circulation before transportation, and no shock was delivered. If all these 4 criteria are met, only then you can consider termination resuscitation. But if only one is missing, you're supposed to continue with resuscitation and transport a person to a place where they can get a high level of care. As far as team dynamics and communications are concerned, always remember closed loop communication is important and role assignment is important. There is a role for the leader and they need to coordinate during resuscitation. The team leader is the one that organizes the group and he monitors the performance. He should be able to perform most of the skills, but not necessarily all of them. Now, we no longer require the team leader to be able to do all of them, but they should be able to do most of them so they can take the place of others when they're getting tired. But the important thing is to be able to direct the team member and able to provide critique of group performance after the resuscitation effort. The group critique is important, but it has to be done in a friendly environment and not meant to belittle anyone. Team members need to understand their role. You cannot ask a respiratory therapist to start an IV. That's his job, to intubate the patient and look into the oxygenation and monitor the ventilator. They should be able to be willing, able, and skilled to perform the role that they assigned. A nurse would be a better person to get the IV in and somebody to write down what medication has been given. And it's important for all the team members to understand the ACLS sequence. They should be committed to the success of the team. Therefore, clear communication between team leaders and team members is essential. And team leader always gives clear assignment to team member. The team member is expected to read back to them what has been called out to that team member. For example, you may say, Jay, I want you to start an IV. Jay will respond back and say, I am starting an IV. I'm looking for the brachial vein and, antecubital vein. Or he'll say, I'm looking for femoral, or I'm trying to put in an intraosseous, Team leader will listen for communication confirmation before he proceeds to the next order to be given. Post-arrest strep defibrillation is equally important. It's important for the lay rescuers because they've seen something that they did not expect to see, and to give them assurance, telling them what they did was correct and how they could improve themselves, and then giving them a little feedback how to improve themselves would be very much appreciated by them. EMS providers are equally important. They see a lot of people making through and a lot of people not making through, as well as the hospital-based healthcare workers. We go through a lot. We see patients doing well and not doing so well, and at the same time, we see people that we may have lost without any specific reason or without our, even though we put in the best possible effort. So in order to help everybody's mental health and well-being, defibrillation is extremely important. For the stroke care, these are the ADs that I don't think we had talked about before. You have got to look into dispatch, delivery, door, data, decision, drug, and disposition. Those are the important ones whenever you recognize somebody with stroke symptoms, and you need to remember those. So the key component for ACLS are listed here, and you need to master them. Number one, basic life support. Without the basic life support, you cannot move forward. Airway management is important. Rhythm recognition is important. The ones that I mentioned to you. Defibrillation and cardioversion is important. The one you use the word cardioversion, it's synchronized cardioversion. Defibrillation does not require synchronization. Cardioversion requires synchronization. Medication administration is important, and it's not necessary that you remember all the drugs by heart. You can carry it in a chart. You can ask your colleague during the code. It's not a problem. Post-cardiac arrest care is important, especially when you're thinking about somebody that you need to send for a cath lab after a STEMI. Is he neurologically awake? Is hypothermia been given to the patient? And look for team dynamics and communication. If you don't communicate with each other, we're not really helping each other. Identifying and treating reversible causes are important, and it's not necessary that the leader is the one that should memorize all of them and say, is this done or it's not done? Anybody in the team can go ahead and put the 2 words in and say, did we look for this? Did we look for that? If anybody who wants to take the lead should be able to do it. Usually it's the person that is noting down what has been done and what to follow is the one that looks for the HNTs as well, mostly. So in closing, the key ACLS steps are: number one, recognizing the emergency, identify cardiac arrest, stroke, or any kind of life-threatening arrhythmias. You need to know how to perform high-quality CPR, chest compression, and rescue breathing effectively. Know how to use an AED or a defibrillator, shock the heart if needed to restore normal rhythm. Airway management, ensure the patient can breathe. For example, using oxygen, using a bag valve. And, those that are in anesthesia, they would go for intubation as necessary. Medications are important. You need to administer medication like epinephrine, amiodarone, atropine as needed. But important part is teamwork and communication. This is important to work efficiently with the medical team for the best outcome. Post-resuscitation care is important. You need to monitor and stabilize the patient, especially after the resuscitation, and move them to an ICU where they can be taken care of. I really appreciate your attention, and I'm very glad that a lot of you have joined. And I must thank my participants, all of you, for joining us. Dr. Amber, Dr. Sadia, Dr. Sahar, Dr. Nazanin, and Waleed for giving your time to put this project together, giving us time for 4 ACLS and BLS classes. And I hope all of you that are participating are taking the exam. Best of luck to all of you. And I know all of you will do well. We are open to question, and any question that is left unanswered or needs clarification, you can direct them to Apna Merit, and we will answer them to the best of our ability. I know there may be a little different variation of how things may be handled by one person or the other, but we will try and stick to the rules. Thank you. Back to you.
Thank you, ma'am. It's really a wonderful way you have, जिसे हम उर्दू में कहते हैं ना, समंदर को कूजे में बंद कर दिया. If someone knows a very nice words for the English, they can share with me. But we have really enjoyed it. That's a long, lengthy, very important topic. The way Professor Mariam has simplified it in a very easy words and way, that's wonderful. Important thing is, which is important for all of us. Sorry, I'm in the cat, and that's why we have to look after these protocols. It is very important. We all should know how to read an ECG, because it is very important. If we don't know what is the underlying rhythm, it's not possible for us to identify and run the code or whatever the patient we are receiving. So all the juniors who are with us, like the house residents and the PGs, the best thing is read every ECG with the full protocol, start from the rate, rhythm, axis, then P wave, PR, interval, QRS, ST, T wave, final diagnosis, because that is the practice with the help of which you can identify the underlying rhythm, whether brady or tachy, what is the cause, ST elevation, ST depression, STEMI, non-STEMI. So the take-home message is, from today onward, all those who are not very well versed in ECGs, please, please, and please go through those ECGs, because then we are able to identify that thing. Professor Mariam, you have covered the things very nicely. Any question which they want, we can ask from our panelists, and they can answer, because most of the questions been very nicely addressed by Dr. Sahar and Nazni. And if there's not something, then we are going towards a conclusion session.
Thank you so much. This is Nazanin speaking. I think one person kept asking me about reflex of tachycardia, Dr. Moten. I tried to explain to best of my knowledge, but the question is that
what's the question?
What is the reflex for tachycardia? And that the same person asked me, what is the basic mechanism of tachycardia? I do believe they need to go to basics of EKG. I try to, respond for AFib flutter, but I don't know if Dr. Moten wants to add anything.
Yeah. Tachycardia is when the heart rate is greater than 100, and it could come from any focus. Usually, if it's come from the SA node, then we call sinus tachycardia. If it's coming from the AV node, then we call AVNRT. If it's coming from accessory conduction tissue, then we call PSVT. It all depends on where it's coming from. Sometimes it can come from the atria around the pulmonary veins or from the ventricles. depending. If it's from the ventricle, we call it ventricular tachycardia. If it's coming from around the pulmonary vein or a different foci in the atria, it could be multifocal atrial tachycardia, it could be atrial fibrillation or atrial flutter. And I think you answered it right. I see your answer. That's, yeah, but sometime, we have to go through
They kept asking, so I thought I was not clear. That's why. Thank you.
That's wonderful. Here, I just want to add one thing for these type of the courses and workshop. Those who are coming and joining, it's better to go through your knowledgeable component, go through these things beforehand, because we are trying to make it more simplified in the way how to apply that knowledge and how to identify those rhythms and act within a second to 1 minute's time, because that's very important. In 1 hour lecture, it's not possible to go through all these mechanism and things. For that, we are conducting ECG workshops. Please do come in that. We have a good time so that we can discuss these things in a better way over there. So in conclusion, if we are going, we have conducted 4 courses. Salute to all of the team and especially to Professor Dr. Mariam Mortar. That's very important. Please go to your institutes and ask your senior faculty to have an hands-on sessions, those who are working in different part of the Pakistan. That's my suggestion. Because with practice, you can enhance these skills and you'll be more beneficial for your patients and for your emergency duties. Secondly, for ACLS protocol and all these things, just revise it and memorize the algorithms. That's very important. If not, you can keep these things in your pocket every day when you come across a patient. If you don't understand, go through it, just find out the appropriate dosage so that we can go ahead with the management of these patients. Third important thing is, after this, all the questions and that is the post test, please do go and fill that, because after that you people will have a certificate. Those who have attended more than 80% of this course content, they have their certificates. Anything which we want to add to that?
Thank you so much. You covered everything, and a lot of people are asking for ECG, so we'll try and put some ECG courses together for them, but we'll make it simplified and easy to do. And as far as some people are asking for the courses again, sure, we can repeat it depending on the time and the need, how people need it. But all of them are already pre-recorded. They are there in a APNA website, and they can listen to it for free. It's not a problem. And I also give them multiple choice question twice, one for BLS and one for ACLS. And if they go through those questions, they should be able to pass your ACLS class without difficulty. Thank you.
That's wonderful. I just want to share, on last Monday, those who have attended your course, out of the 30 participants for ACLS hands-on complete workshop, 9 of them has already completed this course, and they were really very well versed about it, and for them to run that mega code and all the stations were easier. So it's important to go through these courses. Whenever you come and get registered for ACLS with us in Khyber Teaching Hospital in cardiology department, Mr. Hamid is there. He is getting a registration for that. We are not trying to do it as a Sadka Jariya, hands-on, and freshly if you come and do, it will help you people a lot. Thank you, ma'am. Thank you, our worthy, true, energetic these Sahir and Nazneen, and thank you the rest of the team who is looking after all these things.
And thank you, Sadia. Thank you so much, Dr. Number.
Thank you. Have a good day.
Everybody. Thank you for coming.
Thank you.
Appreciate everybody's input. Thank you.